Okay, hello. Thank you all for being here. This question is likely directed mostly to Dr. Fung, although maybe some others. And I did already corner Dr. Tommy Wood for his opinion as well. So I started a ketogenic diet 2.5 years ago, with the primary concern being elevated insulin. And it was up in the 70s for millimole per liter. I've had great success with weight loss. We've tested liver enzymes, and we're not seeing any markers for fatty liver. Now, with that being said, my insulin is still, after 2.5 years, at 14, which is still quite elevated. So the question is, for patients with stubborn insulin, per se, are there different markers we should be looking for, or how far do we need to push fasting, or how many years are we going to be doing this before we can at least see healthy insulin levels?
Well, I think it's quite variable. So it depends on how long you've had insulin resistance. So if it takes many, many years to develop, it doesn't go away in like a few months. But you've been on it for a little while. But if you look at comparison of a ketogenic diet to intermittent fasting, there's a difference. You get very good results. You lower the insulin by about 70% of the effect of insulin fasting you get with a ketogenic diet. But obviously, if you go to zero, then you do much better, because there are other things like dietary proteins which still stimulate insulin. So the way to go up would be to try some of the intermittent fasting or add it, but sometimes you also have to be patient as well. Theoretically, it should come down, but in reality, and I see this all the time, sometimes it just takes a long time. And everybody's quite different. Sometimes it needs shorter, frequent fast. Sometimes it needs longer fast. It's quite different. The only thing I can say is that you have to try these things and see what works for you, because not everything works for everybody, right? So we all know this, right? Somebody does one diet, does super amazing, so says, oh, you should try this diet, and then the next person does it and doesn't lose a single pound, right? So we're all very different, so you have to really look at it. But if you want to lower insulin maximally, really you can't go lower than zero, which is fasting.
Okay, thank you.
And we have a next question.
Yes, hi. Dr. Lemanne, you mentioned Walter Longo. A recent video of his that's on YouTube caught my interest, wherein he's describing his extended fasting program. It's a 7 days on, 7 days off cycle for 3 months. And the idea is, during this extended fast, your body produces new stem cells, which are no longer autoimmune. They're just outnumbered. And so by this cyclic fasting extended, and you're in this production then of replacing, producing new stem cells, that you can, within this 3-month cycle, potentially replace your immune system. And is that, for any of you, something that's really worth chasing? Is that?
Well, I'm not an expert on autoimmunity per se, but in terms of general health, I think that the history of fasting is pretty strong. And going back beyond the typical 100 and 150 years or so of our current medical literature, fasting has been known since ancient times. It was used by Hippocrates to treat epilepsy, for instance. And fasting has been known since ancient times as a very salutary practice. So I think we're just starting to be able to have wonderful researchers like Dr. Longo, who is being very careful in studying what actually goes on during fasting. And certainly if one had some type of condition and wanted to attempt to treat it with fasting, the only caveat, fasting is pretty safe. The only caveat I would give then is there a way to measure whatever it is that you want to measure in terms of your health while proceeding with fasting? And is the process of fasting in whatever pattern you and your physician, I'm being very careful here to say that you need to work with a physician on this, determine is a reasonable approach for you, whether it's 7 days on, 7 days off. That sounds rather difficult for a beginner, but certainly doable. You want to make sure that you have some kind of marker that you're using to measure your success or lack thereof. So for instance, as we're talking about fatty liver, there are many ways of measuring that, all the way up to biopsy, which I wouldn't recommend doing weekly. and there are various blood tests and things like that. So if there's something that in, an autoimmune condition, for instance, can be measured and followed to assess progress, that would be fantastic, and I would say go for it.
Thank you.
I'd just like to add something. Last night, still on European time, couldn't sleep, and I checked the internet, and I saw a paper that came out in Cell from Walter Longo's group on February 22nd. It's open access. You can find it easily. It's before print, in the before print section, February 22nd, and they were able to show that short-term fasting in humans, type 1 diabetics, they were able to rejuvenate beta cells in type 1 diabetics. So that's really fascinating. So look up this. You can look up the paper.
Thank you. Next question.
This is for anybody, but so I eat a ketogenic diet, normally fast 22 hours a day. And what I've observed, a couple of things, one of which is if I do triglyceride testing, that after a meal, a high-fat meal, I'll see a significant increase in triglycerides, and then it'll decline until my next meal, at 22 hours. But then to get with a normal fasting triglycerides, normally around, like say 60, 70 milligrams per deciliter on my normal ketogenic diet. To get them lower, I've found that if I eat a carbohydrate meal and then test, say, at a 12-hour fast, they'll drop into the 40s. And I just wondered if there's an explanation for that for anybody.
Anybody? Dr. Eades, do you think you could? He's puzzled. You've stumped the panel.
Okay.
Crickets. That's all we can hear. Nobody wants to. Dr. Fung, are you? Yep.
Why is this important?
I
don't see the.
It's a curiosity. Well,
I like curiosity.
Okay, so and one doctor we consult with is Steve Gundry out in Palm Springs, and Steve's always trying to get us to drop our triglycerides lower. And I've noticed, and I have an ApoE4 gene, and I've noticed with my genetics that the most successful way to drop the triglycerides is to add more carbohydrates in, have a carbohydrate meal, and it'll drop the carbs. Now, obviously, I don't do that all the time, but it's just an observation, and I was just curious if anybody in the esteemed panel could answer.
I would just ask you to put it in context with every other metabolic activity going on.
Sure.
Not follow just one number.
Right. Yeah, I follow a lot of things. It's just curious. Okay, thank you.
Okay, we might get next question, please.
My name is Patrick Tickman. I work in Las Vegas. Before anything else, I am a holistic doctor because I take care of patients with a whole list of medical problems and a whole list of Google searches. But anyway, a question for Dr. Fung and Dr. Westman. How do you approach patients who come into you who are diabetic with fatty liver and elevated liver enzymes, and they come to you on statins because their previous doctor has been following the NCEP guidelines and they have to meet their Eades scores? And on top of that, too, those patients with chronic kidney disease, stage 3 or 4, how do you approach their protein intake with LCHF?
For me, the second answer is easier. I don't really do much different. It's adequate protein, not high protein. The first question, in 10 years at Duke, the only time another doctor has been bold enough to send me an email about what I do is when I took away a statin prescription from, it was a cardiologist too. So I assess how strongly the other doctor is holding on to the prescription pad, that's supposed to be funny. But relevant to the patient, I mean, a low-carb diet can work even though people are using statins. Usually that's one of the last things that I'll change because of the political climate, unless there are significant side effects. just had someone email me, a local person, who said, "Gosh, I just had transient global ischemia, amnesia. My memory's back. Could this be the diet?" I said, "What else are you taking?" And it's probably a medication side effect. So if there are other effects, I'll screen for those. But in my area, which is very cardiology heavy, university-based practice, I acknowledge that other doctors feel strongly about those things. And as long as it's not harming someone, I won't directly do it. I'll ask the other doctor's permission.
Yeah, I completely agree, because the only time I get into trouble too is when I stop the statin. So it's tough for the chronic kidney disease. So I'm a nephrologist. So the high protein is considered to be bad because it puts more strain on the kidney. That's why in CKD stage 3, 4, and 5, you kind of reduce the protein slightly. But again, we're not advocating a high protein diet. We're advocating a high fat diet. So that's okay. So I don't do anything different either. In terms of the question for statins, I think your question was if they have elevated
Transaminitis.
Yeah, great. So that's perfect. So I tell them, oh, it's your statin, and I take away the statin, right? And but the truth is that it probably was fatty liver disease. And I know that, but it's a great reason to take away the statin, right? So that's what I usually do. And then I put them on fasting, low carb diet, and then their transaminitis comes down, and I say, hey, look, see, it's the statin, right?
Good.
Okay, Jimmy, next question.
Hey guys, so I have a question for all the practitioners on the panel that use a ketogenic diet with patients. Because in Dr. Westman's talk, he mentioned he doesn't give a damn about food quality because it's just about the carb, stupid, basically, right? This is yes, this is no? Is that your position?
It can work.
Okay, that's what I need to know.
Or without, it doesn't mean that's my
So that gets to my question, Dr. Westman. Hold that thought.
Sure.
So when do you introduce, because there's a lot of practitioners in the room, I've met a lot of them this week, and they're probably hearing you say that and go, okay, so when do we broach the topic of food quality? Isn't it important, and do you, I'm just asking any of you on the panel, do you say the goal is real food, and then, okay, if you need to eat a fast food hamburger up front for a few months to kind of get acclimated, when do you kind of say, food quality does matter. At some point, it's about your health and the food quality. I wish I had that message when I did Atkins, because I did Atkins with pepperoni slices and rolled up cheese, and it was awesome, but I would have loved to have known about the food quality piece a lot sooner. So when do you introduce that to your patient population?
Yeah, sometimes never. If the cultural status is such that they can't afford it or can't get it, so some of my patients will always eat at fast food. And if I start saying, and it's working, and then you need to push people toward more, there's a balance, a tension between allowing more and more people to have the knowledge to do this without regard to food quality. And if you wanted the healthiest diet on earth, I'd say, well, of course, have the food quality right there. But our clinical populations are so the food is so distorted, the food quality. If you insisted upon that, even in some people all their lives, they would never be able to do this. So that's the balance. And someone who comes to me who has all the middle class, has money, I said, well, of course, go down to the farmer's market, be very careful about the vegetable oils. And so it's a tension from the gurus like you, Jimmy, who can say, this is the perfect diet, do it.
And I'm not about perfection. I think if you give them the goal is real food, and you say, hey, look, this is what you were spending on your food budget with all the crappy garbage. Here's what you can get for that exact same amount of money you were spending before in terms of food quality. It seems to me if you give the food quality message, they'll find, oh yeah, I can afford it. I can buy in bulk and get those things. I think when you just say, just eat a fast food hamburger, God knows what's in that, you kind of lead them down a road where there's a point of no return if you don't give them the path to what the end goal is, which I think is real whole foods.
I think we're in heated agreement. And
I love you.
Because hey, come to my clinic sometime.
I've been there.
I just tried to show you. Maybe I need to show you the pictures of the people. And
I live in the South too. I
and
know. I know the culture.
Actually, the hardest people to help are those who go to the food pantry, because everyone sends their carbs to the food pantry.
Yeah.
It's hard to do a low carb diet there. So, I'm trying to learn principles that can be applied across the spectrum.
Sure.
And the carb quantity is really the scientific thing. Adding on the carb quality
No argument there.
is great. But it's still, I urge someone to do a study that shows what incremental benefit do you get.
Do that study.
Yeah, well, yeah, I think it's a great study.
Okay, we'll move on to the next question, unless Dr. Fung wants to
Oh no,
add to that.
I agree. I mean, obviously we all agree that real food is the goal, but we have to work with what we got, right? And
We all agree, but we could explore that. There's a
Um,
lot of assumptions that you're making in that statement, and each of them should be carefully examined, or else the rest of your message is put in jeopardy.
I think that
That's jumping the queue, I'm sorry, a bad human.
Perhaps you can have that discussion at lunchtime, but we might move on to our next question. I think over here we have one.
Dr. Lemanne, my question is, will dietary fat negate the benefits or the effects of intermittent fasting on cancer prevention?
Do you mean dietary fats
Butter,
during
MCT
fasting?
oil, correct.
During fasting?
Yes.
Yeah, that's
so
a
if you're
great.
sticking to a condensed eating window, 13 hours, for
Sure,
instance.
sure.
And 16 hours in or what have you to your fast, you consume butter, MCT oil. How does that affect the effects in preventing cancer?
I absolutely don't know. And
Appreciate your
you know,
honesty.
one of the big topics of research right now is the use of exogenous ketones in oncologic situations. Does that help? Does it hurt? We just really don't know. There's an interplay between caloric consumption and cancer growth. Certainly, there's also an interaction between the source of those calories. So how that all plays out, I don't know. I tell my cancer patients, eat a lot of fat, have a lot of space in between your calories, meaning a lot of space in between your meals, and don't eat too many calories. So even if you're on a ketogenic diet, there may be some detriment to overdoing the calorie part of things.
Mm-hmm.
And, the animal studies look to this point as though things are going in the direction of combining caloric restriction with ketosis in cancer. Now, if you don't have cancer, I don't know if that matters at all. But if you do have cancer, that's one of the big questions.
Another question, if you don't mind, could you elaborate on glutamine consumption in cancer? You said 500 milligrams kind of as a threshold. What about post-workout and things along those lines?
Well, if someone has cancer, I think that could be a problem. If you don't have cancer, I don't think that's a problem at all.
Gotcha.
And certain, protein supplements like whey, for instance, has a lot of glutamine in it. And I don't think that's a problem for non-cancer patients. Cancer, there's a new literature starting in 2010 with an article entitled something like Cancer's Glutamine Addiction. And it was published out of University of Pennsylvania and Sloan Kettering. And it talks about how glutamine fits into the citric acid cycle and in the Warburg situation. So, and there's been a lot of research since then that's really held up that particular postulate in a lot of cancers. Now, is every cancer going to be sensitive to glutamine and grow in the presence of glutamine? Probably not. But any cancer that is doing Warburg metabolism is probably susceptible to also high glutamine loads. I picked 500 milligrams just because that's a common dose in protein supplements that my patients bring to me and say, well, can I take this? So, when we're starting up to getting into the gram size of any particular single amino acid, there could be a problem. And it's not just glutamine. It's turning out that we can do PET scans with things like leucine and isoleucine and valine. There are many amino acids that some tumors really, really like, and we haven't figured out the whole landscape of that situation. But no, for someone who's healthy and working out and wants to use whey protein supplements and glutamine, I don't, in reasonable doses, I don't think 500 milligrams or 2 grams of glutamine is going to do anything bad to someone who's already healthy.
Thank you.
Sorry, can I just ask a question too? So for the PET scans, they've done them with the glucose and the amino acids. What about tagging dietary fat? Does that make a difference? Do you see the tumors light up?
I don't know if that's been done, and that's a really great question. I can imagine that it might have been done, and I'll go look, but that would be really interesting, yes.
We have a question over there, please.
Yeah, Ben Mickman. Jason, I wonder, a problem with tagging fat is which carbon do you tag? It's going to go to that one and then it's lost. But Jason and Nicolai, Jason, I liked your focus on the fact that the beta cells recover, so to speak, in type 2 diabetes. And Nicolai, your comment about the type 1 diabetes publication with some evidence of beta cell recovery and regrowth, you'll appreciate this. We have a manuscript in review right now looking at the benefits of ketones on beta cells. And in fact, you feed ketones to beta cells, and they're harder to kill, they grow better, the mitochondria work better, and they create insulin better. Anyway, that's in review right now. Dawn, I had a question for you. I was fascinated to see that cancer cells could use glutamine. On one hand, I guess it's not too surprising given glutamine is a glucogenic amino acid, but could it also be that glutamine is used to produce bicarbonate and to help control the acidic pH that comes from a cancer cell that is undergoing just incredible rates of ATP hydrolysis?
Certainly the ammonia in any amino acid will be used to kind of buffer, the whole process. But no, we think that glutamine is actually what's called an anaplerotic element.
Right.
It actually feeds into the
citrate cycle.
Citric acid cycle. And I'm not a citric acid cycle expert, and I'm probably making people who are here cringe with my very basic understanding. But glutamine seems to be feeding, what happens with the mitochondrial shifts in cancer is that the Krebs cycle is then used to make all of the macromolecules needed to produce new cancer cells. They need a lot of fat for their membranes, they need a lot of proteins for their enzymes, they need a lot of purines and pyrimidines to make all of their DNA. And that's what we think that glutamine is doing in that particular.
Yeah, well, glutamine is unique. Urea, that's NH4, that's providing more hydrogen. But it is a very acidic environment when you're hydrolyzing that degree of ATP. Of course, lactic acid isn't happening in a mammalian cell. But glutamine is unique because it creates bicarbonate, and we know that is a direct buffer to hydrogen. Anyway, it was a speculative question.
There's a big literature on it, and I'm not an expert on that literature, but you might find some answers there, or somebody else on the panel might have an answer.
Great, thanks so much.
We'll just move on to the next question over here.
Hi, Barb Bradshaw, pathologist from British Columbia, Canada. For Dr. Westman, we've had some recent clinical questions come up from physicians in Canada regarding treatment of lymphedema and lipedema, and we don't know the answer to provide them. But I noticed that you mentioned that is one population base that does get referred. So I wondered what kind of successes you've had with your clinic there, and also does that extend to post-surgical lymphedema, such as a post-axillary lymph node dissection, or is it just specific causes?
Yeah, I've seen improvements in both. I don't have a big sample size, probably 5. In fact, we have a very good lymphedema clinic at Duke, and they don't manipulate the diet in any way. And most academic centers use the stockings and other kind of compression hose, and hitting the adipose tissue, losing the adipose tissue, takes away the vicious cycle of adipose tissue, bad drainage, et cetera. So there's a study that received an award last fall by a occupational therapist, and actually she'll be presenting it here in Denver at a meeting. I'll be presenting what I know about the ketogenic diet. So I think it's a good thing to try, even in lymphedema and lipedema.
Great, thanks.
Tommy, your question.
I have a question for Dr. Eades. I loved your talk, mainly because that level of biochemistry is my happy place. And I was wondering if you'd be willing to comment on all the pathways you showed, where there's a difference between what is technically feasible and what is physiologically relevant. And the reason I ask this is because I think one group of people who will be very interested in that topic is athletes, which are the people that I work with, and lots of people trying to improve athletic performance using a low carbohydrate diet. And I think all of the best evidence we have to date suggests that people doing high volume or high intensity exercise using fatty acids or ketones as a primary fuel source, glucose availability is still the rate limiting factor. So if you look at the Volek and Finney faster study, the ketogenic athletes, even though they were oxidizing fat at a much higher level, still depleted glycogen at the same rate, probably because they were using that to generate oxaloacetate by anaplerosis. And similarly, we've discussed with Kieran Clark, who's doing all the work on ketone esters at Oxford, as well as her published work. She shows and says in other groups where she's using these esters but isn't publishing it because it's like they're black box secrets, that if you're giving a ketone ester to improve performance, you don't see that performance benefit if you don't give glucose, because you need to generate anaplerosis. So I was wondering whether you'd be willing to consider that when you have very high levels of metabolism or you have very high levels of fatty acid oxidation, whether the old German adage is actually still correct.
Wow. Yeah, I think it is in high-intensity exercise. Everything that I've seen confirms just exactly what you said, that exogenous ketones and even a ketogenic diet, I mean, they work great for endurance exercises, but when you get into the high-intensity stuff, you've got to have added glucose. And I don't know that any of these pathways are going to give you as much added glucose as you really need for high-intensity exercise without having some problems. And a lot of these pathways, the 22 in the one study, I mean, those were all energetically downhill. In other words, they could happen. They didn't have to climb a barrier to take place and form glucose, but none of them really are going to make glucose in the amounts I think you need for high intensity exercise.
I was just a quick comment. I think there's also a length of exercise thing too, because even Volek and Finney have their very low glycemic carbohydrate supplement, which they give to people doing very prolonged exercise, because at some point you're going to run out of anaplerotic substrate. So like a small glucose drip is still important, even though the intensity is lower. It's just because there's a time thing as well.
Yep.
Thank you.
Thank you. Next question.
Hi, my name's Kathleen. I'm a dietitian from Chicago, and I specialize in parenteral nutrition that's feeding through the veins. And it's sort of an ethical dilemma for me, because a standard formula for a patient is starting about 300 grams of dextrose and about 50 to 100 grams of lipids, and that's made of a soybean emulsion. And then the rest is protein, usually 75 to 100 grams. And for pediatrics, it's actually similar. So usually 250 grams of dextrose for a pediatric with a brain cancer. And so I was just wondering, when I was looking at Dr. Worm's studies about the liver, so TPN is infused and it gets its first pass through the liver. It completely bypasses the gut. And every time we give a formula, we immediately see transaminases, and we also see high triglycerides. And I can't get anybody to, I've looked at the literature up and down over 10 years, I can't get anybody to question why these are the macronutrient ranges we use, and they're based on the AMDRs. So the standard American diet we infuse through veins for these people. So I was just wondering if anybody else was looking at this intravenous feeding and manipulating macronutrients, because it's an area that just has not been studied. And I feel that we're putting people into liver failure with these formulas.
Nobody has experience with this area? Yes. Gary Fitke.
Be careful, you get deregistered. I share, every time I go to intensive care, I cry. So I'm vocalising it. Nobody wants to talk about it, even to try and actually talk about hospital food, which is infinitely less of a topic, is a no-go zone, because it's all about following the guidelines. And this is something which has to change. But if you're in the position you're in at the moment, you're just going to struggle. And I don't think there's anybody out there talking about it. But it has to be talked about because, I mean, I'll go on about the soy component as well. I think that's a disaster. Yeah. Sorry, Ron's got something.
We did a mini study using a TPN solution of high fat, relatively low protein, and almost no carbohydrate in a couple of patients who had a very bad cerebral bleed. And the major problem there is vasoconstriction. And so they had ruptured aneurysm. One patient had a double ruptured aneurysm and wasn't expected to live at all, and she's doing great right now, and that was 5 years ago. Another was a child who had a ruptured aneurysm, also doing great. And we made up our own TPN solution because we know that insulin and leptin both are triggers for vasospasm. They stimulate the sympathetic nervous system. And so my goal there was to minimize the vasospasm by keeping insulin and leptin low. And the only way to do that is to keep glucose and protein relatively low. So we made up our own and did very well. We're just trying to get that written up, and this was done at Cedars-Sinai. And it's a difficult problem, it really is, because we had to actually go through an attorney to allow this because they didn't have a TPN solution that we liked. So it can have incredible benefits, and why it's not known. I mean, the literature on the effects of insulin, leptin, glucose on vasospasm, which is a major problem in critical care medicine, is very, very extensive. So that alone, I think, would dictate a change in the solution that's being used, but certainly hasn't happened yet.
Okay, and Dr. Worm, you just want a quick...
Well, hospital food was mentioned, and that reminded me of I would like to encourage you to look at bed rest studies. You can take young students, healthy young people, and put them to bed for 7 days, and they become insulin resistant, and they need double the amount of insulin after 1 week of bed rest. And then when you think about that and what people get to eat in the hospital, laying there for several weeks, in Germany at least, they get bread and rice and potatoes and noodles, and again bread and rice and noodles and potatoes.
And fruit juice.
I mean, you really force feed them to have a fatty liver when they get out of the hospital.
Dr. Fung?
I'll just make a comment. This is not specific to children in the ICU as well. So TPN feeding in the ICU in critically ill patients, I also cry when I go in there because I think it's really stupid. The point is that your body naturally stops you from eating when you get ill. So if you have somebody who's in septic shock, for example, and you don't eat, what happens is that your noradrenaline goes up, so you support your blood pressure, your growth hormone goes up, which is trying to rebuild your tissue, and your glucose falls because you're trying to lock down all the sugar so that the bacteria can't get at it. And then there's the effects on insulin and so on. So all highly beneficial effects of fasting in critically ill septic patients. So what we do, of course, is shove a tube down their nose and start feeding them to block all these beneficial effects of fasting. And then every time they do a study on early feeding in the ICU, it's negative. And they're like, oh, what a surprise. It's like, why do you think that our bodies are designed? Like, you get sick with the flu, you're not going to the all-you-can-eat buffet, right? You can barely stuff down a little bit of chicken soup. That's deliberate because there's a lot of beneficial effects to the fasting. Right? It's the same when people get ill for any reason. There's a lot of beneficial effects. You don't want to kind of shortcut them.
Thank you for that comment. We've got a question over.
I just need to say a little thing. The primary driver of vasoconstriction is nitric oxide and carbon dioxide. So you have to look at that. It's not only nutrition. Okay?
Thank you for that comment. We've got a question here.
Yeah, so recently there's been a lot of press on the follow-up studies to the contestants of The Biggest Loser. And so, that's basically pointing to Lot of exercise combined with caloric restriction, and it's having this lasting, very damaging impact on their, metabolism. And so the question is, what's the mechanism there, and why, how can we be comfortable fasting and knowing that we're not, damaging our metabolism? What, can you talk about that a little bit and help us to understand the difference between what they're doing and what fasting would be adding to an exercise regime that we might do?
Yeah, it's a very important question. Unfortunately, it's quite a lengthy answer, probably not appropriate to this. But the point of the Biggest Loser studies is that caloric restriction reduces your metabolism. So you're eating less, but you're burning less. So therefore, they're not losing weight. Right. What was very interesting in the New York Times article was that there was one person who actually raised his metabolic rate back up. And what did he do? He did bariatric surgery. So what was the point of that? The point is that when you fast, it doesn't slow your metabolism, right? If you look at studies of fasting, and they've done a number of these, over a period of 4 days, your metabolic rate doesn't go down. So at the beginning of the fast and at the end of the fast, your metabolic rate is actually 10% higher. There's also studies that was done early last year, 2016, which showed that if you do alternate daily fast, also the amount of decrease in your metabolic rate is like 3 times less than when you do caloric restriction. So it's not the same. It's not about calories. It's about the hormonal changes that you get with fasting compared to caloric restriction.
What's the difference between caloric restriction and fasting, though?
It's because the fasting lowers insulin and insulin resistance better, and it switches you from burning calories that you eat to burning calories of fat on your body, because that's what fat is. It's just stored food energy. It's there for you to use when you don't eat, right? That's all. So if you're constantly eating, you're telling your body to store food energy. That's natural. So therefore, you're not burning it, right? If you fast, you force your body to burn some of it. So then the body's like, oh yeah, there's lots of this fat calories, so let's burn it, right? So it's not the same. So it's a very important question. But there is a difference between basal metabolic rate changes with caloric restriction and intermittent fasting. That's the short answer. It would require a bit longer answer.
Thank you.
Thank you. Going to fly through questions if you've got one.
So my question is about cholesterol and non-alcoholic fatty liver disease. So I do primary care, and I've had some recent patients come in where they have diabetes and they have large central obesity. And when I run the initial labs, they have normal LFTs, but their total cholesterol is really, really low. Total cholesterol, triglycerides, LDL is all like lower than most normal people. And so I just thought it was odd that it was very low. And I even checked extra labs like GGT and hepatitis. Those were normal. But then when I went and did the liver ultrasound, they showed moderate to severe non-alcoholic fatty liver disease. So I guess my question is, would anybody else be alarmed if the total cholesterol and other cholesterol panels were really low, and why does that happen? Nobody? No?
It's not, it's not typical. I mean, lately, there has been a lot of publications on the ratio of triglycerides to HDL cholesterol, and if that is above, I mean, if triglycerides are high and HDL is low, your ratio goes up to 2.5, 3, 3.5, and if you're above 3.5 as a male, it's a very clear indication that you're insulin resistant and you have fatty liver. So this would be a normal situation. So I don't really know what's happening with the patients that you're talking about.
I was trained in a Veterans Affairs evidence-based medicine model of if you weren't going to change what you did by a test, you don't do the test. So that's in that realm of I would still do the same thing regardless of what your test showed, which would be get this person to a better state of health, regardless of what the cholesterol was.
Okay. The only thing I can think of is that the vast majority of the cholesterol is made in the liver, and if people have a real severe case of fatty infiltration of the liver may be compromised to some extent, and so it's not producing as much cholesterol as it otherwise would. I mean, that would be my guess.
That was my thought, but I didn't know if there was a better answer to it. I just assumed that the liver was so sick that it wasn't making the cholesterol, and that's what forced me to do the ultrasound, because otherwise I wouldn't have done the ultrasound, because I had no indications other than looking at them and seeing they look like they have fatty liver disease, but I don't have X-ray vision, so that's why, yeah.
Yeah, well, that would be my call.
Okay.
I mean, textbook knowledge or recent publications, they point to a small dense LDL as a typical aspect of fatty liver disease. Normal cholesterol, total cholesterol, normal LDL, but the LDL is small and dense. That goes along with low HDL and high triglycerides.
I have time for just 2 more quick questions, unfortunately. We're really running over. We'll just take one from
Okay,
you, if you don't mind.
I'll make it really quick. My question is in regards to addiction, and I heard it mentioned a couple of times, and I guess I would just like to ask, how do you advise your patients who may have issues with sugar addiction or binge eating, or how have they taught you?
Stay away from the drug. If sugar is your drug, you stay away from it. So we have a lot of sugar addicts. I'm a reformed one. Did you steal from your mother's purse to go buy candy as a child? No, that's not normal. And yet, who didn't do that? So yeah, you just stay away from the drug. If you were trying to help someone quit smoking, would you say, oh, we'll just have one cigarette every now and then? Of course not. So that's my approach. If someone wants to read about it, they don't believe it, get Gary Taubes' book, The Case Against Sugar, that just came out last month. It's unbelievably clear. It's addiction, it's in our food, it's in our drinks, and it shouldn't be.
Is there any advice on how to kick the habit? I mean, you could go a day, but you have cravings the next day. How do you curb that?
Well, that's where in the medical model, we use methadone or Suboxone to get people off heroin. We use nicotine patches to get people off cigarettes. So getting sugar-free options to get people off sugar, to me, is a reasonable medical alternative. And of course, it violates the perfect food preaching, but as a practical thing, it helps so many people to have a sugar-free option at first.
One thing I learned from the diet doctor, Bitten Johnson, is live joyfully in that abstinence. So that's one thing there also I ran across.
Thank you. We'll just have time for one more comment. I'm sorry.
So I have a question for Dr. Westman. I have a client with fatty liver disease and type 2 diabetes. I really want to throw her on a ketogenic diet, but she has no gallbladder due to past health implications. So
no problem.
No problem?
No
Okay.
problem.
Thank you.
Exactly.
No problem. No problem.
Just that the metabolizing fat, some people think that missing a gallbladder, they won't be able to metabolize the fat. Can you just expand on that just a little?
Fortunately, the liver makes the enzymes to digest the fat, whether you have a gallbladder or not, to hold the enzymatic digestive material. So, yeah, it's interesting that one may think you'd have to have one, but the practical clinical experience of Dr. Eades, doctors who did this for the last 50 years, and then me the last 10 years, we treat many, many people without gallbladders, and it doesn't seem to matter.
Okay.
Yeah, and the interesting thing, some people form sort of a pseudo gallbladder after the surgery that kind of takes on the role of the gallbladder, but there's really not a problem. What's interesting, we did a study that we were involved with for Hoffman LaRoche on one of their weight loss drugs, and we did the maintenance arm of the study, and so people had to lead in for 6 months on low-fat diets, and we ran this whole plethora of studies on them at the start, one of which was a gallbladder ultrasound. And on low-fat diets, 10% of patients that were in our clinic developed, or that were on this arm of this program, developed gallstones.
Wow.
In 6 months on a low-fat diet. So, your gallbladder has got to be squeezed. I mean, it's got to be cleaned out. And when it does that because you eat fat, that's what it stores the bile for, to emulsify the fat. And if you're not squeezing that and emptying the gallbladder, that can sit in there and supersaturate it, can form stones. And that's what happened to these people, I'm assuming, the 10% that develop gallstones with a low-fat diet. And that's not unique to us. I mean, it was unique because I saw it with my own eyes, but that's, I think, a pretty common figure.
Just one more.
Low-fat diets.
And Dr. Berger, if you'd like to make the last comment.
Just on the pseudo gallbladder, a lot of patients who have cholecystectomies, we see on imaging their common bile duct gets quite dilated, and you can get a common bile duct up to 10, 15, 20 millimeters in size, and the normal size is about 6. So they act kind of as this reservoir. So we do see that on occasion.
Terrific. Thank you so much. I know that, yep. We will return at 2 o'clock. If you've got any more questions for the speakers, maybe try and find them in the break. But please give one more large round of applause for our speakers. Thank you.